Yeah, so the question was in terms of sleep apnea surgery, what's the success rate? So everyone's different. So yeah, usually the quotes are usually about 30 to 50% success rate. And usually over time, especially over 10 to 15 years, usually the effects will tend to diminish over time. Depends what kind of surgery that you have. So usually the surgery will tend to focus on the upper airway in terms of doing it. And so one of the things that will usually be done is they'll usually laser out the thing that hangs down at the back of the throat. So to a certain extent, you could argue and say that doesn't have much of a function. The only function that it does have is sometimes if people eat things, sometimes it'll keep the food from going up into your nose. So there's a substantial proportion of people, if they have that surgery, they can present with what they call regurgitation of food, where they'll eat stuff and it'll go up the nose. In terms of phonation, there's a lot of things that affect your voice, in terms of what goes into your voice. So it wouldn't surprise me if, depending on how much surgery they do in the back, it definitely could affect your voice in terms of the resonance. Now, they don't do anything with the vocal cords per se, so it shouldn't make you really hoarse or anything like that. That would be a bit atypical, but definitely it could affect the resonance of your voice as well. But the major side effect is usually the regurgitation of food. The other problem as well is that for individuals who get the surgery and where their uvula is cut, one of the issues you get into is if down the road that person needs the CPAP machine. The problem is that when you put people on CPAP, one of the things that uvula does is it actually blocks the mouth so that the air can go through your nose and into your lungs. So in some individuals where the uvula has been cut off, sometimes they can have a lot of problems, using the CPAP machine under those conditions as well.
So you actually cut that right off?
Usually, yes. It depends what kind of surgery you have. So if you have it done in the office, they'll usually just laser off, whatever they can get to with the uvula. If they think it's a more severe case, one of the things they'll do is actually bring you to the OR where they'll take out your tonsils and your adenoids and they'll sew up, the redundant tissue and do it. So that's the more severe UPPP operation that used to be done. In my opinion, yes, but again, I'm not an ENT surgeon, so I'm a respiratory doctor. So again, you kind of do what you're most comfortable with. So I'm sure that if you go to an ENT surgeon, he may give you a different answer from what I've given. So most of my patients I put on CPAP first. If that doesn't work, then I'll usually go with the dental appliance. And if that doesn't work, then some of those patients I might send to surgery as a last resort. The only exception would be some individuals who are kind of younger and thin who present just with snoring but don't have very much in the way of sleep apnea, and they just want to get something done about the snoring just to preserve their relationship with their wife. Some of those individuals I have sent for surgery as long as they understand that they may have problems down the road.
So one question has to do with Zopiclone.
Okay.
Can it hurt or help in any way?
Well, I think that Zopiclone, so the question was Zopiclone can help or hurt. So Zopiclone is basically a medication it's used for sleep. And it's similar to Ativan or these other sedatives, but not as strong. So definitely anything that can affect the upper airway, or anything that causes sedation in general can affect the upper airway. Now saying that though, Zopiclone is a fairly weak sleeping medication, so I think that the impact that it would have on your sleep apnea would probably be very low, but definitely, I can't rule out the possibility that your sleep apnea may get a little bit worse. The other thing about Zopiclone is Zopiclone tends to be very short acting, so it's usually gone after a few hours, If someone is using CPAP regularly, then it's not really that big of an issue because you can use the sleeping medications. If you're on CPAP, the CPAP will take care of your breathing anyways, so it sort of depends on the context.
So is there a possible problem with CPAP machines that use humidifiers? Has there been any association with lung infections? Does it put you at risk in any way?
I don't think so, although to be honest with you, I've had some of my patients complain of that, but I don't know if it was related to the CPAP or not. One of the things that can happen is if you don't clean the CPAP machine on a regular basis, I've seen some patients where they get almost like, if there's some fungus, in the machine, then they can get almost like an allergic type of reaction to the machine. So I think that if you didn't clean the machine properly, something like that definitely could happen. I think that if you actually did clean the machine properly, I think the chance of that happening would be very, very low, Saying that though, I have had some patients, complain of that, although to be honest with you, I'm not sure whether, it's a cause and effect thing.
Are there any exercises that can be done to improve the tone in your upper airway?
That's interesting because one of the bosses I used to work with, he did this study where, he was sending patients for like, singing lessons kind of thing. So he was getting them to sing and stuff like that to kind of see if that would improve their sleep apnea. And basically he never published it because it was completely negative, so it didn't really work at all. And so his theory was that, if you're singing and you can strengthen the upper airway during the daytime, but the problem you get into is when you go to sleep, the airway shuts off anyways. So it doesn't really matter how strong it is because once it shuts off, it's down. Now saying that though, there was a paper that was published a few years ago where some people have argued that there was this didgeridoo that you can play, that the Aboriginals play in Australia, where it's more like circular breathing. So basically what they do is they breathe through the machine, but they don't like breathe and then take a breath in or breathe and take a breath in. So they breathe through their nose kind of thing, and then the air goes out circularly through their mouth, so they actually never stop playing. So some people, you know, in that small study, there was some suggestion that maybe this didgeridoo playing might actually affect the upper airway. But I think it's, you know, it's a good idea, but at this point, you know, I can't really recommend any kind of strengthening exercises or tongue exercise or anything like that that would help at this point.
So the appliances that you had showed for the treatment, are they covered by pharmacare, and how expensive are they typically?
Well, unfortunately, even though we live in a, I guess, in a public healthcare system, like none of the treatments for sleep apnea, other than surgery, is really covered by MSP. So I think that for most CPAP machines, you have to pay either out of pocket or you have to get your insurance to pay for them, and same with the dental appliances as well. So even for the dental appliances, you have to pay for them as well. Usually, most of the extended health will actually pay for CPAP, and they're pretty good about it. Sometimes for the dental appliance, it can be a bit of a problem because, you know, some health insurance companies think it's more like dental care, but it kind of falls between dental care and medical care, so then basically you just don't cover it. So, you know, you kind of have to go to your insurance company to kind of see if it's covered. So what some companies will do is they'll pay for one and not the other. So, you know, if you think you're going to go for an appliance or for CPAP first, you know, you should kind of make sure that, you know, it may pay for one, but it may not pay for the other as well. Now, I think there is a provincial program that if you can prove that you have a life-threatening sleep apnea, that you might be able to get it paid for by the government, you know, but that's a very recent kind of thing. But yeah, it is a problem because you could argue and say that, well, if you have someone with severe sleep apnea where you're kind of worried about them driving and things like that, you know, it seems kind of silly for the, you know, state not to pay for that kind of thing, given that there's sort of a public health impact of it as well.
And how much is are the machines per month?
No, you usually buy the machine. So usually what will happen is if you go to a company, they'll usually give you the machine for free for about a month or two just to try it out. And if you try it for a month or two and you return it, there's usually, you know, there's really no cost associated with that. If you actually want to purchase the machine, it's usually about $1,500 to $1,800, you know, so it's actually fairly expensive. For the dental appliance, you know, the dental appliance itself is not that expensive. It's probably about $300 or $400, you know, and in fact, you can get one on the internet for like $150 or something. The thing that you pay for with the dental appliance though is that usually you want an orthodontist to fit it for you, because the major side effect, or one of the major side effects of a dental appliance, is teeth migration. Because if you have a dental appliance in, what happens is that your top teeth will tend to kind of bow inwards, and then your bottom teeth will tend to bow outwards over time. So you kind of want an orthodontist to actually monitor your teeth to make sure that you don't have a lot of teeth migration as well, and that's what sort of drives up the price of them. So I think the price for a dental appliance is actually similar to that of CPAP roughly, but again, it really depends on what dentist you go to.
Okay. And if somebody can't sleep on their back, can they still have the sleep study done?
Yeah, and to be honest with you, a lot of times people can't sleep on their back because they do have bad sleep apnea. But anyways, if let's say you had a back problem or something like that, you know, and you can't sleep on your back, you definitely can get a sleep study done. And in fact, you know, the thing about the sleep study is that sometimes we actually have people sleep on their side for the whole night just to kind of see if there's a positionality to it as well. So there are some patients with sleep apnea where they'll just have it on their back, because when they lay back, the throat can close up, but then on their side, they don't have that much sleep apnea. So in some individuals, what we've done is we've tried to study them in various positions just to kind of see what the positionality of it is. So, you know, whether you can sleep on your side or your back doesn't preclude you from getting a sleep study.
And in terms of tests, how accurate would you consider a sleep disturbance, especially people changing sides, they have leg problems, or having hot flashes, they have a lot going on? Yeah,
obviously there can be some night-to-night variability, and it depends what kind of test that you do, you know. So let's say, for instance, if you go home with that oxygen test, the issue you get into with that oxygen test is we don't really know if you're actually asleep or awake. So let's say, for instance, if you took an extreme case where you didn't fall asleep at all during the entire night, then obviously, even though you might have bad sleep apnea, it wouldn't show up on that test. In general, if you come to the sleep lab, you know, if you have it one night, you do have it most of the night, so that test is pretty good. The only thing that the sleep study may actually miss is some individuals with bad limb movements of sleep, you know, where people get these leg cramps and can wake them up a lot at night. Some of those individuals, you know, they have a lot of night-to-night variability, so if you don't catch them on the right night, you know, you might not be able to see it. But in general, with the sleep study, it's pretty good. For some of the stuff that you do at home, depending on how much you sleep and everything, that's variable.
76 years old, and about 20 years ago had a sleep study done at UBC and was found to have sleep apnea, and lost about 8 pounds and has been healthy from that
okay.
point of view. And what the person wants to know is, if they keep the weight off, what's the probability of it happening again, like getting sleep apnea? And how should this person be prepared for it if that were to happen?
Oh, well, it's good that you lost weight, so that's good. You know, usually what will happen is the sleep apnea will tend to get worse as you get older, you know, from some of the mechanisms we talked about, because the upper airway gets more collapsible as you get older, just because it gets less stiff and you lose the connective tissue. So definitely after 20 years, it's definitely possible that the sleep apnea could come back, you know, after that time period. Again, it tends to be more related to weight, so it's more in patients who gain a lot of weight where the sleep apnea will really come back that we're more concerned about it. But definitely, you know, if someone has sleep study 20 or 30 years ago, if they're having more symptoms now, it definitely could come back even though their weight has been about the same as well. So all I could say is that, you know, if you're feeling fine, there's probably nothing to be done about it. If you are feeling some of the symptoms that we talked about, then I think getting checked out would definitely be something to consider if you think it's, you know, something that you know, you'd be wanting to warrant therapy.
So this person has had a pulse oximetry test done at home, and it was supplied by a CPAP vendor. And should this person be rechecked by a medical professional?
I probably would if I were you, not knowing the, you know, obviously some of the CPAP vendors are fine, and, you know, I guess everyone's got to make a living and these kinds of things. But obviously, like, you know, if you go to somebody who's actually doing the test to diagnose you and they're also selling the device, obviously there's sort of a clear conflict of interest there. And so, you know, I probably would want to get another test done by the hospital just to kind of verify that what was there was, you know, was correct. But, you know, not knowing the exact situation, it would be difficult for me to advise. But yeah, I think that if I was me, I would probably want to get a test. Now, saying that though, if you felt really bad before the machine and you got the machine, and you're feeling way better, and your snoring's gone away, and you feel better, then you know, then obviously it was the right thing to do. But if there's sort of any inclination that, you know, you don't really feel that much better, or you felt that, you know, the test was equivocal, then yeah, I definitely would get that checked out.
Okay. So what percentage of people who have sleep apnea are actually obese, or what percentage are they of people who have normal body weights have sleep apnea? And the other thing is, what's the distribution for men and women?
Yeah, so in terms of moderate to severe sleep apnea, usually in most of the epidemiology studies, it's about 9% in men and 4% in women. So that's for moderate to severe disease. So I would say that, you know, it's usually about a 2-to-1, you know, split, you know, males to females. In terms of, you know, the obesity, definitely obesity is a risk factor for sleep apnea. But saying that, though, I can't quote you an exact proportion, but a substantial proportion will actually be thin. So I've seen some individuals who are rail thin and have really bad sleep apnea, you know, even in the absence of sort of bad tonsils or these things. And there's obviously something genetic about the way their airway is shaped, or their control of breathing issues. So just because you're really thin doesn't rule out the possibility that you have sleep apnea. The other thing that's interesting is that if you actually look at the various populations around the world, so let's say individuals from Asian countries, their prevalence of sleep apnea is about the same as that in North America, but their body mass indexes are much lower. So it's almost like, you know, individuals from Asia, because of the structure of their face, actually maybe it may get sleep apnea even at lower body mass indices. So definitely in someone who's from Asia, you know, I'm actually more keen to think they have sleep apnea even if their body mass index isn't particularly high.
And if a person's diagnosed with obstructive sleep apnea and they have choking and gasping when they're lying on their back, but don't appear to have these symptoms when sleeping on the side, would you conclude that side sleeping is not apnea generating?
Well, the problem you get into is that, you know, a lot of times when people wake up at night, that's usually more the tip of the iceberg. So a lot of times, even if they have bad sleep apnea, they'll say they wake up 3 or 4 times at night. But if I study them in the lab, you know, a lot of times they'll wake up 100 times an hour, you know, when we study them in more detail. So I think that, you know, in that sort of in the individual, I would suspect that the sleep apnea is probably worse on their back, and it may be completely on their back, but certainly possible that it might be on the side if we study them. So, you know, just because there's no witnessed apneas, you know, on the side but only on the back, you know, wouldn't necessarily mean that it's not there, you know, on the side.
Does having tonsils and adenoids increase your risk of having obstructive sleep apnea?
You know, that's interesting. Like, you know, in epidemiology studies, in individuals who've had their tonsils or adenoids out, when they were a kid, actually have an increased risk of having sleep apnea when they actually get older. And why that is, we're not too sure. You know, some people have argued and said that, well, maybe when you have your tonsils out, you know, there's more scarring and stuff that might do it. Some people have argued that, you know, individuals who get their tonsils or adenoids out usually have some other structural abnormalities of their airway as well, so we don't really know. The other thing is that in you know, young adults or in children, a lot of times the large tonsillar adenoids might be actually the cause of sleep apnea. So there are individuals, especially in kids, where they have very, very big tonsils, and they complain of snoring and stopping breathing at night, and a lot of those patients will actually respond to actually getting their tonsils out.
So what's involved with the overnight hospital tests in terms of cost, and what's the usual follow-up?
Well, there's obviously no cost associated with it because it's part of the medical services plan. It's a diagnostic test, same as all these other things, should actually be covered by the medical services plan. But basically what would be involved in it is that usually you would have to get your family doctor or your specialist to refer you to the sleep clinic at UBC, and then myself or one of my colleagues would see you, and if we thought that the sleep study was indicated in you, then you would be booked in for a sleep study. So it really depends how emergent the test is. Like obviously we have a fairly long waiting list, but if it's somebody who, that's more of an emergency kind of thing, so let's say for instance they're very sleepy during the daytime or have underlying heart disease or lung problems or these things, then definitely we can get you in a lot quicker, if your doctor says that it's an emergency as well. And so usually after you see me, then after a few weeks we get you in for the sleep study. And basically what you do is you come in around 8 o'clock, 8:30, and you leave about 8:30 the next morning. Other than the wires and everything that you have to go, that's the major thing, but there's really no cost or anything associated with that.
And physiologically, how does obstructive sleep apnea cause atherosclerosis?
Well, what we think happens is that because of the low oxygen levels, it just results in a lot of changes. And so I think that in general, the body's not really designed to function with low oxygen levels. So that when that happens, this basically triggers a lot of physiologic changes. So the first thing that happens is that, when the body, basically the body's being suffocated, with your tongue at night, this really sets off this fight or flight type of response, and so the blood pressure will go up and there's activation of the sympathetic nervous system, and then there's vascular changes as well and shearing along the vessels. In addition, when you drop the oxygen and you give oxygen back, you get a lot of activation of inflammation as well, which probably inflames the blood vessels, which causes a problem as well. Now, saying that, though, we don't know exactly the causes of atherosclerosis and the disease, but it does seem to be associated with premature atherosclerosis.
And more heart attacks and strokes.
More heart attacks and strokes is where most of the signal is, and what we think happens in strokes is that because of the shearing of the vessel that occurs when people have the apneas, like I showed you before, like when the oxygen level goes down really low, and then you get this huge surge in blood pressure and this huge surge in heart rate. What that does is it tends to shear a lot of the smaller vessels, especially like in the brain, and it's thought that that's why individuals with sleep apnea have a very high risk of stroke. In addition, it's been shown that there's something called aortic dissection, where basically what will happen is the aorta will have a little hole in it, and blood will be pushed along it and basically shear the vessel. And it's thought that patients with sleep apnea actually have a very high risk of that as well compared to the regular population.
If you can talk a little louder.
Oh, is that right? Oh, okay, sorry.
Yeah. So is there a statistical association between obstructive sleep apnea causing arrhythmias, conduction problems like ventricular tachycardia?
Yes, there is. The major thing that sleep apnea is associated with is actually atrial fibrillation. So some of the atrial arrhythmias are strongly associated with sleep apnea. And it's been shown in some of the studies that if you have someone with atrial fibrillation and sleep apnea, if you actually don't treat their sleep apnea, it's very difficult to control their atrial fibrillation. So that definitely in patients with sleep apnea and atrial fibrillation, then that would be a strong indication to treat. Definitely in individuals with really bad sleep apnea, what can happen is that because of this sympathetic nervous system discharge and the high blood pressure and this fight or flight response, some individuals who are predisposed to having ventricular tachycardias can get ventricular tachycardias during those times the oxygen level is low. The other thing that's been reported in sleep apnea is actually bad bradycardia or very slow heart rates as well. So especially at the part where the person is really trying to breathe hard, a lot of times the heart rate will actually become very low at that time as well. And in fact, some patients with sleep apnea actually require a pacemaker, just to speed up the heart under those conditions.
I think there's one more question coming.
Oh, okay. Well, by convention, anything less than 60 would be considered low. But in patients with sleep apnea, you're talking like in the 30s or 40s. And the thing you're more worried about is if there's actually a complete heart block, where the atrial activity is completely gone, and that you're relying on your ventricle to generate the heart rate. So, and that definitely has been reported in patients with sleep apnea.
So does the lack of oxygen, is it associated with inflammation in the joints or the soft tissues? And has there been any studies around obstructive sleep apnea and its association with arthritis?
That's actually a good question. I've never seen any studies that have published that, but saying that though, I have seen some individuals where we've treated their sleep apnea and their inflammatory arthritis has gotten better. So I remember a patient with psoriasis, who we treated with sleep apnea and their psoriasis, and the arthritis associated with the psoriasis got better. So even though I haven't seen any studies on it, it wouldn't surprise me because we do know that patients with sleep apnea can trigger the systemic inflammation, so that with the systemic inflammation, it wouldn't surprise me if that could actually trigger some of these other things. The other thing that's been shown as well.
They're closing the hospital. It just happens every time at 8.
Fire.
Attention visitors, the time is now 8 o'clock. Visiting hours are now over. Thank you and have a great evening.
Yeah, and then there's a lot of things about pain and sleep as well. So what's been shown is that if you take someone and you sleep deprive them, they tend to experience pain more than if they're not sleep deprived. So if you have someone who's sleep deprived and they have any kind of pain from arthritis or from reflux, their pain will actually get a lot worse if they're sleep deprived. So even though I haven't seen any studies per se of this, it wouldn't surprise me that if you had someone with bad sleep apnea whose sleep was very disrupted, it wouldn't surprise me that things like, pain or depression or all these other things would probably get worse. I think the way that I would look at sleep is that sleep provides you that buffer zone so that it allows you to be resilient to certain diseases or resilient to certain things. And the issue you get into is if you lose that buffer from sleep, you're probably less likely to really deal with a lot of medical issues. But although I've never really seen that written anywhere, that would be my gut feeling in terms of how I would look at sleep as more of a restorative type of function.
Is that anecdotally based on the patients you're seeing and also with the work you did with the residents?
Yeah, I think a little bit of both, So anecdotally, I've seen that with patients, but it's one of those things that kind of makes sense. Like, if anyone's had the experience where they've stayed up all night, you can think about how you feel the next morning and how if you're under some kind of stress or pressure, you probably wouldn't do that well. So if you had someone with bad sleep apnea, it's basically being like that every single day. Now, again, you kind of get used to it over time. So I think that the issues with patients with bad sleep apnea is that they kind of feel bad all the time, but because they felt bad for 20 years, they don't feel any different at all. And it's only after they get treated that they kind of, have an understanding of how bad they actually really felt.
Right. And how long would it take before you notice a difference, usually using the CPAP machine, if you're able to tolerate it?
It depends. Like, usually you should be able to see a difference in a few days. Some people have taken a couple of weeks. So usually what I tell my patients is that don't give up on it unless you've really tried to use it for 2 or 3 weeks. So if someone has used it for 2 or 3 weeks and don't feel much better with it, then that's usually pretty good data from my standpoint to say, I don't think the sleep apnea is causing your problem, then I think it's usually something else. I know some individuals who feel better after a day or two or after even one night of CPAP, but it really depends on the person. The other thing to remember is that, a lot of people have sleep apnea, so it's in 5 to 10% of the population. A lot of it will be fairly mild. But in terms of symptoms of tiredness, the issue is that there are a lot of other things that will make you tired during the daytime as well. So if you've got insomnia, you're not sleeping well because of some kind of medical disorder, a lot of medications can interfere with your sleep, as well. So just because you have sleep apnea doesn't necessarily mean all those symptoms are caused by the sleep apnea. So a lot of times what we'll do is we'll treat people and see if the symptoms get better, and that's actually pretty good evidence to kind of show whether the sleep apnea is actually causing a lot of the problems.
Okay, great. Are there any other questions out there? Yes?
Just a quick question, if I may, maybe the other way around.
It could be like, a lot of the, just to repeat the question, you described your wife has arthritis and you feel that because of the arthritis she doesn't sleep very well and you're wondering whether it could be the other way around. I know a lot of these things in medicine, they tend to feed on themselves. So, definitely people with bad arthritis, anybody with any kind of chronic pain disorder can have poor sleep. But the issue you get into, it's been shown that if you have poor sleep, that can actually make the pain worse as well, So I know, and again, I'm more of a respiratory specialist, so I don't deal much on that issue, but some people have argued and said that, if you can actually make the sleep better, you might be able to control the pain a lot better as well in patients with chronic pain disorders. So, some people have argued and said that, you really should try to find something that can really help the sleep if you can, to do it.
So should she get her sleep study done?
Well, I guess it.
Because her GP cannot help you.
Oh, okay. Well, it depends. Like, I think that, if the sleep is really a concern, you could definitely send her to the sleep clinic and see, depending on whether we thought it was sleep apnea or not, either we may or may not do the sleep study. You know, again, I'm more of a respiratory doctor, but we have other doctors in there who deal more with more chronic insomnia or these kinds of problems that might be able to find some kind of drug or something that could actually help both the chronic pain as well as the sleep as well. So there are a lot of drugs that can actually do both, you know, and I would suspect that you know, those would be the type of drugs I would be looking at in your wife's case, but not knowing the case well enough.
Sure.
Just to repeat the question, sure. You said you had atrial fibrillation and you're taking a sleeping pill once in a while, and you're wondering if that's okay. Yeah. You know, the issue is, you know, we don't usually like having people take sleeping pills every day, because what happens is then your body becomes used to taking the sleeping pill, and then over time the sleeping pill isn't as effective. So, and then what will usually happen is that you'll have to go up on the dose of the sleeping pill, and then you have to go up even higher on the dose until it doesn't really work anymore. So usually what I've told my patients is to try to minimize the amount you're taking the sleeping pill to about 3 or 4 times, you know, per week maximum, if you can, just to give you that little bit of a holiday, you know. But I think that taking a sleeping pill once in a while probably isn't really that big of an issue. The issue is that, you know, with the atrial fibrillation, like obviously, you know, patients with atrial fibrillation are at fairly high risk of having obstructive sleep apnea. And I think that, you know, before taking a lot of sleeping pills, I'd probably, as a physician, I would probably want to know whether you did have sleep apnea or not, because that might kind of change the way that I would manage that. But, you know, it's just more of a general comment.
Thank you.
Yeah, welcome.
Are there any other questions? If not, I'd like to thank you for coming out tonight for this session. And we're not going to have a session next month because of the holidays. But our next session in 2012 is on January 19th. It's by Dr. Alex Chan. January 18th, sorry, it's on a Wednesday. And it's Let's Talk About Addictions. And so you're welcome to come between 7 o'clock at this location. So I wish you all a happy holiday season and a new year.